we need to know about the pharmacokinetic as well as the rationale of the drug. The rationale is, in any case when we cannot use heparin, like in HIV type 2 patients, we need a reliable drug, and direct thrombin inhibitors, particularly bivalirudin, serve the purpose. And let me increase the size of the slide a little bit so we can see it closely. So this is a recommended dosing regimen using bivalirudin for cardiopulmonary bypass. For bypass, start with 1 milligram per kilogram body weight of bolus, and then start an infusion of 2.5 milligrams per kg per hour. Add 50 milligrams of bivalirudin in the circuit, on the pump circuit. The target value is more than 10 microgram per ml. Now, you may ask, how do we know that the patient achieves this value, more than 10 microgram per ml? As we discussed previously, the ACT value it has a linear pharmacokinetic, so the ACT value, which we use to monitor the anticoagulation property and the level of, along with bivalirudin, it can tell us if the ACT value is 2.5 to 3 times of the baseline, we can be sure that patient is achieving more than 10 microgram per ml concentration in the blood. But in any case, if it is not achievable, say for example the ACT is within 2.5 times of the baseline, then we can add either give a bolus of 0.1 to 0.5 milligrams per kg bolus, or increase the dose from 2.5, say increase to like 3 milligrams per hour. But we have to repeat the ACT again afterwards. After the bolus, throughout the cardiopulmonary bypass duration, we need to continue an infusion of 2.5 milligrams per kg per hour until we are about to separate from the cardiopulmonary bypass. About like 15 minutes before the separation, we can discontinue the infusion of bivalirudin. But if by any chance, if the discontinuation from the separation from the cardiopulmonary bypass is not possible within 15 to 20 minutes, then you need to start the infusion again. Otherwise, there are chances that the anticoagulation is reversed now. So give a bolus of 0.5 milligrams per kg and start an infusion of 2.5 milligrams per kg per hour again. Well, if we are using bivalirudin, we have to do ACT every 30 minutes, 15 to 30 minutes. If the ACT is low, less than 2.5 to 3 times of the normal baseline ACT, repeat a bolus of 0.1 to 0.5 milligrams per kg. What we do at the end of the bypass. Now, at the end of the bypass, there are 2 strategies which are recommended, because we don't want the blood to clot in the system, in the bypass circuit. One of the strategies which is commonly used is empty the circuit blood into the cell saver and fill the circuit with citrate sodium. The other less usable technique is combine the arterial line with the venous line and add more bivalirudin in the system and keep it circulating. So either one of these 2 strategies are useful because we do not want circuit to be clotted, as all of us know that circuit needs to be on standby till the patient is leaving the room. So this was the bivalirudin strategy for bypass patients. Now, what is the drug regimen for patients not going on bypass, for bypass surgeries? For the off-pump surgeries, the target ACT value is more than 300 seconds with bivalirudin. The doses are low, as we know about. So rather than giving 1 milligram per kg of bolus, we can give 0.75 milligrams per kg of the bolus and start 1.75 milligrams per hour infusion rather than 2.5. If the ACT is less than 300, we can increase the infusion by 0.25 milligram per kg per hour or administer a bolus of 0.1 to 0.5 milligrams per kg. When do we need to stop it? With discussion with the surgeons, we can stop it anytime once the proximals are being placed in and we know that we don't need anticoagulation too much at that point. So a recommendation is you can stop it anytime after, like 15 minutes prior to the graft flow restoration. The important thing is the surgeon needs to know that we are using bivalirudin and what we are concerned about. We are concerned about that because of the shorter half-life of the drug, the blood can clot. So in the grafts, when they are done with the distals, or they're putting the proximals on, they need to understand that the blood should keep on circulating through the grafts to avoid any thrombosis of the graft. So just remind the surgeon to let blood go after every 15 minutes or so that the bivalirudin concentration in the blood present in the grafts should remain in adequate therapeutic range. What evidence do we have? Do we have any experience of bivalirudin being used in bypass surgeries? So the literature has a lot of case reports as well as some good studies which are in favor of using bivalirudin in patients where we cannot use heparin. These are like a couple of studies which showed bivalirudin can be easily managed, easily replaced with heparin. The first study done by Mary and colleagues, they used bypass patients. It was a multi-center randomized study. Their outcome was they measured the perioperative blood loss. The blood loss value was about the same. It's like 793 ml versus 805 ml, which is not significant at all. Which shows that if you use bivalirudin, the amount of blood loss is not more than when we use unfractionated heparin. Another famous study, there was a famous trial, evolution on and evolution off. On for on pump and off for off pump. So in the evolution on was an open label, it's multi-center trial with 2-to-1 ratio. Two patients were treated with bivalirudin against one patient of heparin. They studied 98 patients with bivalirudin and 52 patients with heparin. In all sort of patients, either primary, redo CABG, or valve surgeries required bypass. Outcomes goals were 30 days and 12 weeks, complications which include death, MI, stroke, requiring another cardiac intervention, either a PCI or another surgery, another cardiac surgery.